Thank you for the introduction. I can tell you, we want to thank MIS for the invitation. It's a real honor for us to be here and on this amazing stage. As you can see, our topic of today is guided surgery, and within the next 40 minutes, we want to give you some insights on how and when we are using guided surgery in implant treatments. And we also want to try to explain if guided surgery is the fast, the reliable, straightforward procedure, as some of the companies claim, or if we need someone that is leading the dance and knows how to handle when something goes wrong. We are going to talk about patients like this because we wanted to prove guided surgery for full mouth rehabilitation. Those are not easy cases. We were thinking if guided surgery works for those patients, it works for every indication. These are patients that suffered for a long time with intraoral problems, infection, that ultimately leads to extraction of teeth or teeth that were extracted in the past. They also suffered from hard and soft tissue loss, in a lot of the cases quite substantial amount, and it is our belief that to solve this, we believe in, just like the previous speakers, that the prosthetic solution for this tissue loss is much more easy than to solve this in a surgical way, because it will make the surgery less extensive, and it will also make the aesthetic outcome more predictable.
Moreover, I think we should not forget about the non-dental factors associated with this type of patients. A lot of them are not used to regular dental visits. Most of them fear treatments involving anesthesia. So once they made the decision to start a treatment, mostly upon a long time of hesitation, they don't feel like waiting anymore. Most of these decisions are related to personal events like a divorce, a retirement, maybe heritage. And they hope that this decision to start a treatment will affect their lives in a positive way. So as you will notice, a lot of these patients generally experience a far more functional and macro-aesthetic treatment instead of a high-end micro-aesthetic treatment that you have already seen some beautiful presentations today. So as for today, we're going to present two patients, both conventionally named Patricia. So the first patient is a 67-year-old grandmother. She's still very active, taking care of her grandchildren. She has suffered from breast cancer around 5 years ago. She still smokes a little bit. Her former dental history was she was partially edentulous at age 30, changed to a fixed dental bridge, dental supported at age 55, and she comes into the office with a complaint of some difficult to define pain. So these are the intraoral pictures. We see a combination of pink and white ceramic, a grayish aspect of the lower anteriors, and also some old composite restoration. We also noticed the root caries on tooth number 23. So looking more intraoral, the lateral views and the occlusal views, we can see these wear facets. Always be aware of those, because those are probably signs of a parafunctional habit. The X-rays show a good overall periodontal condition, especially concerning the age of the patient, and which is confirmed by the periapical radiographs. However, we notice some periapical periodontitis around tooth number 26 and 16. So diagnosis of this patient, we have a low negative smile. I think video is a good tool to analyze smile. So we have a low gingival smile, no gingival display, a midline shift. We have a tooth-supported 13-unit bridge, the apical perio, the problem of the 23. She complains of this diffuse pain and also some migraine attacks. She wears a hard splint at night that was provided to her from the dentist who made the fixed bridge. So going into her main complaint, because that is important. We should always respect the complaint of the patient when they come into your office. So talking about this pain, I think the etiology could be tooth-related, occlusion-related, neurologic, or myogenic. However, if we listen to the interview of the patient, she strongly tells us that the symptoms, the onset of the pain is strongly correlated to the placement of the 13-unit bridge. So how are we going to approach this kind of patients? As we all know, I think planning is crucial in this kind of situations. So I suggest this 5-step approach, where step 1 will be to determine the remaining dentition, determine the prognosis. We're going to design a new setup to reconstruct function and aesthetics, simulate the new design, evaluate it, adapt our provisionalization, re-evaluate, so we can get to the final step where we have to copy our provisionalization and get to our final prosthetic work. So step 1, we send the patient to the endodontist. She segments the 2616, evaluates, concludes that they are lost. I duplicate the provisional bridge, remove it, check the preparations, make a new provisional bridge. So we lead us to this situation. So we have a provisional bridge from 15 to 25, and as only 2 teeth are in the upper jaw are still in kind of a good condition, we suggest for extraction of all upper teeth in terms of long-term fixed restorations. The patient, however, is without pain, which strongly suggests that their pain was really related to the fixed bridge. So, step 2, getting into our design. We were in contact with Francis and Christian Coachman from DSD Virtual Lab to transfer my 2D DSD design to a more 3D setup. So important in our design will be the position of our centrals. As you can see, we will have a more of a subtractive case. We will reposition the centrals. Patients strongly demanded to have a fixed restoration. So we're going to need to find the balance between implant positioning and lip support. So when we have our design, it's crucial to get to a final treatment plan. So in this case, we're going to first test drive our design with a mock-up on the upper and lower jaw. We're going to install a new occlusal plane. As you might remember from the first intake pictures, this patient had a negative smile. So that means her canines were lower than the centrals, incisors. So we're going to adjust this to have a more positive smile. We can only do this if you also respect the occlusion, so we have to do something in the lower jaw as well. Continuous, we're going to do an immediate loading upper jaw, guided surgery, evaluate all our provisionalization, so we can get to our final prosthetic work. Installing this new occlusal plane, before we get to the mock-up. So when we get to the mock-up, you change the position of the central incisor, the incisor ledge position. It's very important to evaluate phonetics. So I have my patient saying a lot of words with F and V sound to see if there's any conflict with the vermilion border of the lower lip. Once the mock-up is accepted, we can continue our treatment. To install this new occlusal plane, we used the STL file. From DSD Virtual Lab, I got this 3D printed mock-up, wax-up, and a hard and a soft retainer. So I'm going to use these 2 retainers to transfer my 3D model, 3D printed model, into the patient's mouth. A hard retainer to stabilize this transfer, a soft retainer to give me more details. So the protocol will be, I'm going to rough this ceramic surface, going to ceramic etch it, use cojet, silane, let it evaporate after 60 seconds, use adhesive and composite. All done on the rubber dam. The advantage of this very simple protocol is it's very easy, and we work with composite, so it's adjustable. You can add composite, you can remove if necessary. Furthermore, it's a very non-invasive approach. No anesthesia was needed, so if we would do a classic prosthodontic approach, that would mean we will need to remove all the old crowns, have probably subgingival preps, which will be much more difficult to manage with our provisionalization. Also, we postpone future interventions, so also for the patient, financially, it's a good suggestion to postpone the treatments. So, immediate loading, guided surgery in the upper jaw. When we talk about planning and we want to use guided surgery to have our planning to our actual treatment, we should be aware of the accuracy of this planning and our treatment. So talking about accuracy, what we're going to measure is the global deviation between our planned implant and our actual installed implant. We both know that all these errors that can happen from the data collection through CBCT over the transfer to a surgical guide and the actual treatment, all these errors are cumulative and they can interact. Looking at some literature about this topic, from 2003 to 2014, we will see that the mean global deviation will never be less than 1 millimeter. And I think from an oral surgical point of view, that's a lot. But even more, we should also be aware of the maximal deviation, considering the location of our planned implant. This accuracy will be influenced by our implant length, our tube length, the positioning of the guide, the support, and the mucosal thickness.
Can I interrupt with this? Because I believe this is a very important topic now. During one of those accuracy studies, we decided to analyze not only the preoperative plan, the deviation with what was actually placed in the mouth of the patient, but we analyzed the mean inter-implant distance of the pre-op and related this to the mean inter-implant distance of the placed implants. And we saw that those deviations were much smaller, 0.2 millimeter, compared to the deviation of 1 millimeter. That actually means that when you install the surgical guide in the mouth of the patient, that this has a very big impact on the deviations.
Also, if we should also focus on the mucosal thickness, and we see, according to this study, that a smoking habit influenced the mucosal thickness and also has a bigger impact of the global deviation of our guided surgery. So in conclusion, when we want to work with guided surgery and want to focus on accuracy, I suggest we have to support, use tooth-supported guides, as Eric already mentioned 2 hours ago. We should go for implant guidance. Be aware of the guide sleeves, because when we have wear of our sleeves, or if the position of the sleeve is too high from the bone, that will affect our angulation of our implant. Also, try to reduce the number of the templates, and if possible, use fixation of our guide.
Okay, so we spent quite a lot of time and effort in designing the ideal prosthetic plan, and of course, we want to transfer this ideal plan to the surgeon. And here you can see some of the implant positions with the software, the planning software. We are looking for the most ideal, the optimal position of the implants related to the tooth position for every location. This translates into a surgical guide, and the first surgical guide that we're using is a guide that is tooth supported. Remember, using teeth to support your guide improves accuracy. So we're using this guide only to drill the fixation pins, and afterwards we will use those fixation pins with every step during the surgical treatment. Here you can see a occlusal view, and then afterwards we take out the first guide, and extract very carefully the remaining teeth, because some of the positions, the alveolar sockets, we wanted to use for implant placement. So this is done as atraumatic as possible. And then, instead of just drilling through the mucosal tissues, we make a little flap and move the tissue towards the buccal to improve the tissue volume on the buccal side, as you can see over here. Then this is the drill guide. This is one of the previous generation of drill guides. At that time, it was only possible for the V3 implant to use drill guides that guide the sequence of drilling the osteotomies. However, placing the implants itself was not possible at that time. This was done, I believe, a little bit more than 1 year ago. So the implants were placed with a free-handed approach, but the osteotomies were guided with the drill guide. After implant placement, we will install multi-unit abutments, torque them in the correct way, and then afterwards, with the temporary cylinders, will be realigned in the mouth. And then something very smart came from the lab as well. We had something prefabricated, a provisional prosthesis prefabricated, that was also using the same fixation pins to make it possible for us to position this acrylic stand in the exact position as it was planned on the computer before. So this is relined into the prosthesis. And here you see an occlusal view of the provisional prosthesis after healing. Extraction, implant placement, and immediate loading is something that we already do for some time, and we do not have a very impressive list of literature as the previous presenters, but this is something that we, at that time I was working at the university, investigated and published ourselves, and we can say today that immediate loading is a protocol that is evidence-based. At that time, in 2009, I started my office, and this immediate loading became part of our implant treatment, and I can tell you that today it became a standard protocol for full mouth rehabilitation patient. Last year, when we started with the V3 implant, we also included this for our immediate loading cases. In 1 year, we treated a total of 9 patients, 11 jaws, 61 implants, and 1 implant got lost. This was actually our own fault because this 1 implant that got lost did not reach enough sufficient primary stability. We included it anyhow in the provisional prosthesis, and consequently, it failed. We have 3 cases in the mandible, 8 cases in the maxilla, and most of the cases, except for 1, except for 2, were restored on intermediate abutments. And actually, this is the way to go, because it makes the life of your prosthodontist much more easy. And in the maxilla, the 2 cases where we used guided surgery are the 2 cases that we are presenting today. The question is now, why did we use guided surgery for those 2 cases? As Alexander was explaining to you before, in the first case, guided surgery transfers an ideal preoperative plan to the surgery. But you have to understand the system. You need to realize that there are certain deviations. You need to realize about the accuracy and how to improve accuracy. So that means if you have a very good support in partially edentulous cases or for single tooth replacement, today it is possible to almost completely prefabricate your final implant restoration before the implant is even placed. However, for full mouth rehabilitation, we believe that still today we need to make an impression or realign temporary cylinders in a prefabricated stand, as you can see here. This to counteract for the deviation, to counteract for the errors included into this guided surgery protocol. Guided surgery also facilitates a surgical procedure. That means that it will make it more predictable. Some parts of the surgery are going to be a little bit more fast and less invasive. Take into account that you have maximum deviation. So that also means that when you're planning your implants, do not plan them too close to very important anatomical structures. It is also operator dependent. For example, in a case like this, I feel confident with my surgical skills to do this with a free-handed approach, a classical surgical free-handed approach. But there's going to be other people that want to do guided surgery, and this is okay. However, realize that if you do guided surgery, that at any time you will have to be able to take out the surgical guide if something goes wrong and do your classic surgery if you cannot use the guides anymore. Guided surgery also facilitates the lab work. Don't think that it's going to gain you time. If you want to reduce the amount of time you spend with your provisionals after the surgery, then you will have to invest this time in front of the computer. This is necessary. So we think, or we use guided surgery in cases where we do not want to make an impression and send it to the lab, but when we want to do a one-day treatment, or for example, in cases that undergo general anesthesia, and we want the patient to wake up with the fixed solution already in the mouth. This brings us to the second case, Patricia number 2. And this is a very special patient. She was treated recently, and when patients come into our office, we take a standard protocol of intake pictures. And when I asked her to smile, this is the maximum that she could give me. This was her smile. Maybe my jokes are very bad, and I asked her, and we tried, but this is what she could give to me. She was very embarrassed, and you will see immediately why. This is her intraoral situation. A massive amount of hard and soft tissue loss because of periodontal destruction. So what we did for Patricia is we took all the records that are needed, and we virtualized this patient. And with the same tools, as Alexander was explaining you before, we were trying to make a virtual tooth setup related to the macroaesthetics that was needed for her case. We also asked our dental technician, Benedict Vernijen, who is in the room, and I appreciate all the hard work that you did to finish this. I know it was a busy time the last couple of weeks, but Benedict also milled the same tooth setup in this acrylic stand that you can see on the right side of the screen. Here you can see some of the screenshots of the implant planning that was done with the MGuide software, and we planned to place in a guided approach 4 implants in the upper jaw, and with a free-handed approach 6 implants in the lower jaw. At the day of the surgery, and we started very early in the morning, this was done under local anesthesia. We started, and after a couple of minutes, we started to extract all the teeth except but 2. 2 teeth, one in the upper, one in the lower, we kept for as a validation to position our tools. And then, secondly, and something that is very critical and very important, especially when you do immediate loading procedures in the upper and the lower jaw, occlusion and articulation is always a problem, and you need to spend some time in doing a correct bite registration. And we were using this acrylic stand, this tooth setup, after extraction of the maxillary teeth in the mouth to find a good bite registration and also trying to validate the correct vertical dimension. Then we continued with the surgery of the lower jaw. This was done with the approach exactly as the previous speakers were explaining to us. Open flap. In most of the cases, you have to adjust surgically, go into the defects. We wanted to reduce the alveolar ridge. There were some bone defects that are quite substantial. We did the osteotomies, we placed the implants, and you heard that one of the prerequisites to go for an immediate loading protocol is to have your implants primary stable enough. So sometimes we go in and back to have the correct implant stability. Installed multi-unit abutments on the implants that we wanted to use for loading. There was one implant that was not stable enough that we left unloaded with quite a big bone defect that we treated with a combination of biomaterial, PRF membranes. And then we usually take the impression copings that go onto the multi-unit abutments, and before suturing, you can check the impression copings if they are seated correctly, and then we start suturing, and then I ask Alexander to make an open tray impression of the situation. This is sent downstairs into the basement where we have the dental lab, and Benedict starts to work on the prosthesis. In the meantime, we continue with the upper jaw, and this was done with a guided approach. So we check the surgical guide, and this is one of the guides of the newer generations, together with the new surgical kit that also makes it possible not only to drill through the guide, but also to place your implants through the guide. You can see that we planned 6 implants. 2 were as a backup, but we planned to place only 4 implants, 2 in the anterior part. This is something that I prefer to do before, first place the anterior implants, and then use the implant mounts that are in your surgical set and fixate your surgical guide onto the implants that are just installed, just as an extra. The 2 posterior implants were placed inclined because of lack of bone, maxillary sinus. You also have to realize when you place implants through surgical guide that because of the friction of the sleeves, that you always have an overestimation of primary stability. This is something you have to take into account. Then afterwards, when the implants are placed, we take out the guide and install the multi-units, 2 straight multi-unit abutments on the anterior implants and 2 angulated multi-unit abutments on the posterior implants. Then it was, again, time for Alexander to reline temporary abutments into the provisionals, and we finished the day, after a long day of working, with extraction implant placement, upper and lower jaw, and immediate loading. This is a situation, the intraoral situation after 1 week of healing, normal healing, no significant postoperative events happened, and this is her smile at the same day, 1 week, a little bit more, 1 week and a half. This is the time now that Patricia, number 2, has to gain confidence with her new intraoral situation. She has to smile again. She has to start using and functioning with her provisional bridges. And we ask our patients to do this for a longer amount of time, several months. We ask them to wait for a year until we switch to the final restoration.
So getting back to Patricia, number 1. We come to a situation where we have to adapt our provisionalization and reevaluate this. Use a lot of time to listen to your patient, listen to their remarks, respect their remarks. So in her case, she felt some retention of the upper lip, so we had there was too much of a gap between the buccal plate and the cervical level of our in new central incisors. Also, although it's a very nice design, in the end she found out that the 2 central, the dominance of it was a little bit too much for her. She said, I'm already 67 years old, no need to make me 40 or 25 again. But worse was the fact that she noticed that her pain symptoms returned, and she also noticed this grinding habit. So at this point, what you have to do, our options are to do occlusal adjustments. We have composite in the upper and in the lower jaw, so we can add or remove. So we check again for premature contacts during guidance, and we have to make sure that we deprogram any muscular activity when we get to our final bite registration. So this deprogramming was done together with Sophie Velde, who won the Young Clinicians Award yesterday. So congrats for that, Sophie. So when we got to this point where the patient no longer feels any pain, is satisfied with the provisional situation, we can get to our last step, which is the execution of our final prosthetic work. So it's the classic daily dentistry approach where we have our impression, also the gypsum lock, as was mentioned before, to fit the model. We had this, Benedict designed this peak structure we used with the bite registration, and eventually it led us to this zirconia framework that we will check to see if we have a passive fit. Once this is okay, Benedict can start with the ceramic layering, as you can see, leading us to the point where we have the biscuit try-in. At this stage, it's very important to take enough time to look at this biscuit try-in and see, evaluate the occlusion, evaluate Pontic design, see where we need to add more pressure, see how if oral hygiene instructions can be sufficient, and if you need to adapt on this biscuit try-in, I recommend you to use low or middle speed, use a fine diamond burr, low pressure, water cooling, and make sure that your dental technician does a new glaze. So finally, we get to the final work. So the day of placement, it looks like this. Having our intraoral views, we can see that on the occlusal that all screw access holes are very nice inside our arch, covered with composite, so you cannot see it. And this is the evaluation of the lip support, which I can say is more than adequate. So this is the patient today. So she's without pain for the last two months. So she knows that after summer we will continue with our final work in the upper jaw. She's also wearing a splint just to help me to see if there's still any grinding habit. So I can see after a couple of weeks or months if there are still signs of grinding. And this is our final result. So Tommie, how do you now feel about guided surgery?
Well, let me tell you a story, Alexander. I'm actually very happy to be here today, because yesterday when we arrived at the airport, we realized that our flight got cancelled. And normally, when you have to take a flight, you buy your tickets, you go to the airport, you check in, you go to the gate, you take the flight, and you arrive at your destination, and you do not even realize how many steps it takes for you to go from A to B. You do not realize until something happens, and you see all the little steps that you need to fill in the forms and try to solve the problem. And this is actually the same, I think, with guided surgery. In a certain way, the system is very good, and you have to rely on it. But if we ask ourselves, who is taking the lead, I think it is you. It is you that takes the lead, and with your knowledge and your skills, need to control every little step to bring your patient from the beginning to the end. Thank you very much.